Today we'll be discussing about vasomotor rhinitis. What is rhinitis? Rhinitis is an inflammation of the nasal mucosa. Rhinitis can be caused due to an infectious cause or a non-infectious cause. Infectious cause, your bacterial, viral, fungal infections. Non-infectious rhinitis can be divided into allergic rhinitis and non-allergic rhinitis. So today we are discussing a cause of non-allergic rhinitis. Vasomotor rhinitis is a non-allergic rhinitis. It is also known as idiopathic rhinitis or non-allergic, non-infectious perennial rhinitis. NANIPER. These are all other names for vasomotor rhinitis. There are 9 categories of non-allergic rhinitis. It can be drug-induced rhinitis, hormone-induced rhinitis, hormonal rhinitis, gustatory rhinitis, that is food-induced rhinitis, atrophic rhinitis, senile rhinitis, non-allergic rhinitis associated with eosinophilia, that is NARES, and also rhinitis associated with CSF leak. These are all primary causes of non-allergic rhinitis. There can be secondary causes of non-allergic rhinitis like rhinitis associated with autoimmune disease, polyangiitis with granulomatosis, Turk-Strauss syndrome, Carter-Jenner syndrome, laryngopharyngeal reflux disease, chronic fatigue syndrome, acromegaly, metabolic syndrome, cystic fibrosis. All this can cause secondary non-allergic rhinitis. So we are going to discuss about vasomotor rhinitis, idiopathic rhinitis or NANIPER. What is the pathophysiology of vasomotor rhinitis? It is not caused by allergy. From the name, what can you decipher? Vasomotor. Some problem with the nerve supply to the vasculature of the nasal mucosa. The most common reason that is studied and explained is there is an imbalance between the sympathetic, parasympathetic and nociceptive supply to the nose. So the sympathetic supply causes nasal vasoconstriction. It is mediated by norepinephrine and neuropeptide Y. The parasympathetic stimulation causes mucus secretion or rhinorrhea, which is mediated via the acetylcholine. The nociceptive fibers from the C fibers from the trigeminal nerve. The sensory neuropeptides and the nociceptive fibers contribute to nasal degranulation and also sneezing and itching reflexes. There is an imbalance between all this supply causing rhinitis. Some studies show that any mechanical stimulation like a forced expiration can also be a stimulus for developing vasomotor rhinitis. So mechanical changes in pressure, changes in humidity can also stimulate vasomotor rhinitis. What are the clinical symptoms? The clinical symptoms are mostly common to allergic rhinitis, like rhinorrhea, nasal block, sneezing, all that can happen. But the sneezing, pruritus, and all that will be lesser in vasomotor rhinitis compared to the allergic rhinitis because it is not allergy mediated. Also, the vasomotor rhinitis patients present later in age, that is more than 30 years of age, studies show that vasomotor rhinitis is more common in females than in men. How do you diagnose vasomotor rhinitis? The diagnosis is mainly clinical. We have to go in a stepwise pattern. A detailed, comprehensive history has to be taken. The patient will have sneezing, nasal block, nasal discharge, sometimes headache. So the chronic symptoms will be present. You have to take a detailed history as to when the symptoms are present. So if it is an allergic patient, the patient will say that there is increase of symptom to exposure of the allergen or dust exposure will cause increase of the symptoms. Allergic rhinitis is usually seasonal. Vasomotor rhinitis is perennial, that is, it is present throughout the year or it is present throughout the life. And the trigger factors can be like any humidity, raining, or any cold or hot air exposure, any perfumes, that is odor of the floor cleaner or patient traveled in somebody's car which had a perfume, alcohol intake, spicy foods, all this can trigger vasomotor rhinitis. So you have to ask what is the trigger factor. Also, you have to ask and rule out any viral or bacterial infection, any symptoms of upper respiratory infection, any fever, any purulent rhinorrhea, any cough, facial pressure, all this you have to rule out. A detailed head and neck examination has to be done. The diagnosis is mainly by exclusion. The vasomotor rhinitis patients can be classified broadly into runners and blockers. That is, runners means the patient is having constant running nose, that is rhinorrhea. So in such patients, there is increased parasympathetic activity causing mucus secretion and rhinorrhea. Blockers patients, there is increased predominantly nasal congestion, so their nose will be blocked. So this is mainly due to the nociceptive stimulation. That is, a normal stimuli itself is stimulating the nociceptive receptors, the C fibers, causing severe nasal congestion and sympathetic hypoactivity. You can classify clinically with the patient symptom into runners and blockers. On examination, you will have boggy edematous nasal mucosa and turbinates. There can be clear mucoid discharge. These patients can also have associated adenoid or tonsillar hypertrophy. You can do a diagnostic nasal endoscopy to rule out any other pathology, any polyp, sinusitis, status of the middle meatus, etc. can be observed. The main two tests that differentiates allergic rhinitis from a vasomotor rhinitis is in allergic rhinitis, there will be IgE positivity. In vasomotor rhinitis, IgE levels will not be so much raised. And also, the specific antibodies will not be raised. The skin prick test will not be positive in a vasomotor rhinitis. But allergic rhinitis, you will get a positive skin prick test. So you can do a serum IgE levels, serum antibodies to specific allergens can be done. A skin prick test can be done. Nasal cytology can be done. That is, just take a scraping from the inferior turbinate or the mucous discharge can be sent for a cytology and assessed for the cells. If the lot of eosinophils are present, you can classify it as the NARES. Also, provocative testing can be done, like expose the patient to stimulants and assess for symptoms, and also objective data with the rhinomanometry and acoustic rhinometry can be collected. Also, if you are in doubt, you can do a CT scan to rule out any other sinus pathologies. There's a questionnaire called Brandt and Bernstein questionnaire. It is an irritant index scale. You can assess the severity of the vasomotor rhinitis. Classify the vasomotor rhinitis to mild, moderate, severe, depending upon the symptoms of the patient. The diagnosis is mainly by exclusion. Rule out infectious and allergy cause, and there is no IgE skin prick test negative. Patient have symptoms adult onset, and also vague triggers like any smell, alcohol, spicy food, all these triggers, you have to think about vasomotor rhinitis. What is the treatment for vasomotor rhinitis? First of all, you have to explain to the patient that patient is having this kind of a situation. Better to avoid the external stimuli. So better to avoid the floor cleaner that causes the nasal congestion. So that has to be done. Medical treatment. The most effective medical treatment for vasomotor rhinitis is intranasal steroids. Sprays you can give. Intranasal corticosteroids are first line, especially for congestion and obstructive symptoms. Fluticasone, beclomethasone, budesonide, all the three are approved by FDA. Other intranasal medication that you can use is ipratropium bromide nasal drops. That is anticholinergics. This is mainly useful in patients having rhinorrhea, that is continuous running nose. What about antihistamines? Oral antihistamines do not have much role in treatment of vasomotor rhinitis. You need not give your Vontac LC. It does not have much effect. Some studies show that first generation antihistamines may be useful in vasomotor rhinitis. Because of their anticholinergic activity, they can reduce some rhinorrhea. Second generation and less sedative antihistamines have no role. But topical antihistamines are found to be effective for vasomotor rhinitis. Acylastine is the one that we are using. So acylastine is also a histamine blocker, but the effectiveness for the vasomotor rhinitis is not because of its antihistaminic activity. Acylastine also has anti-inflammatory activity. It reduces the inflammatory cells, the cytokines, leukotriene, etc. So this can relieve the nasal congestion and can have an effect. So we can also use a combination of fluticasone and acylastine for vasomotor rhinitis. There's no need of giving an oral antihistamine. There are also other treatments recommended by many studies. I will outline them. But the thing is, allergic rhinitis patient will respond very well to your treatment. If the patient is not responding so much, and the response to steroids are also like 50% only, you have to think about vasomotor rhinitis. Other treatments are intranasal capsaicin. Capsaicin is basically an irritant. It desensitizes the TRPV receptor. We said earlier that there is some problem with the nociceptive receptors also, the C fibers. So what this capsaicin will do is it desensitizes it. Many patients may not tolerate. What about topical decongestants? Your silometazolin, oxymetazolin and all that. Actually, topical decongestant will decongest anything. Allergic rhinitis, acute infection, or if it is a vasomotor rhinitis. But it is not usually recommended. The recommendation is to give any oral decongestant like pseudoephedrine or phenylephrine. But pseudoephedrine and all have other side effects, so you have to monitor for that. Main thing is topical decongestant. Patients may overuse. If you are giving for an acute attack, give only for 3 or 5 days. Use for more than 10 days is proven to cause rhinitis medicamentosa. About rhinitis medicamentosa, I will be discussing in another video. Another treatment is botulinum toxin injection. It inhibits the acetylcholine release. So you can inject the botulinum toxin onto the inferior turbinate. The relief is only for short duration. The patient will have to go for repeated cyclical injections. Some patients cannot prefer that. What is the surgical treatment? Are there any surgical treatments that can be done? If the inferior turbinate is very much hypertrophied and boggy, you can do a mucosa preserving inferior turbinate reduction. It will reduce the obstructive nasal symptoms for an extent. So after that, also the patient has to be on intranasal corticosteroids and acylastine. Another treatment that has been done is therapeutic transection of the Vidian nerve, Vidian neurectomy. What is Vidian nerve? Vidian nerve is a nerve to pterygoid canal formed by the greater superficial petrosal nerve and the deep petrosal nerve. Greater superficial petrosal nerve contains the preganglionic parasympathetic secretomotor fibers from the facial nerve to the lacrimal gland, nasal mucosal glands, etc. And deep petrosal nerve contains sympathetic fibers from around the internal carotid artery. These two join together to form the Vidian nerve. So once we transect the Vidian nerve, the secretomotor supply to the nose is cut off. So the symptomatic relief can happen. In persistent rhinorrhea, persistent refractory rhinorrhea, this can be done. Previously, open approach, transandral approach has been done, but this is found to have a lot of side effects. Now, endoscopic approaches are being done. Nowadays, we perform posterior nasal neurectomy. So, the posterior nasal nerve is a parasympathetic nerve coming from the pterygopalatine ganglion. So, it is easily accessible. And via endoscopic approach, you can do a posterior nasal neurectomy, which is found to be almost as effective as Vidian neurectomy. Vidian neurectomy has a lot of complications like reduced lacrimation, numbness over the cheeks, palatal gingival numbness, and nasal crusting, etc. Posterior nasal neurectomy is found to be better. The posterior nasal nerve enters the nasal cavity just posterior to the middle and inferior turbinate, so it is easily accessible endoscopically. You can do cryogenic ablation, cautery, laser ablation, gallbladder ablation. Lot of methods are being tried. How do you treat in pregnancy? Pregnancy, actually, in 60% of pregnant women, they can develop hormonal rhinitis also, especially in the third trimester. In pregnancy, mostly it is conservative management. You can give a nasal irrigation, a saline nasal wash that can be done to relieve the symptoms. In certain cases, if it is refractory and patient is unable to sleep, you can use topical nasal decongestant like sildenafil for a brief period of time. What is the prognosis? The vasomotor rhinitis is quite difficult to treat. It can present lifelong. It can worsen also. The patient can also develop chronic sinusitis, asthma, etc. What are the complications? The complications are mainly quality of life related. So the quality of life will be affected. The patient will not be able to go to places which trigger the vasomotor rhinitis. There can be poor work performance, poor school performance, and due to medications, the patient can feel drowsy. The epistaxis can develop sometimes palpitations. These patients, because of continuous nasal condition, can develop obstructive sleep apnea symptoms and complications related to that. To summarize, vasomotor rhinitis, non-allergic, non-infectious, perennial rhinitis. That itself gives everything. It is no allergy. So diagnosed by negative skin prick test, negative IgE, diagnosis of exclusion. Treatment is mainly intranasal corticosteroids and intranasal antihistamines. So inferior turbinate reduction can be done as part of surgery. Another treatment is posterior nasal neurectomy. Thank you.